Hey everybody, we're going to go over some aspects of the physical exam for infants and children. I'm not going to go over every single slide because we've got 72 slides here and I just don't think it's going to be helpful, but I will go over the ones that I think are the most relevant to you. I think this is a really important course that you're going to be taking. I've been a nurse practitioner. I'll tell you a little bit about myself. I've been a nurse practitioner since 2009. I've been a nurse since 1990. So I've been a nurse for a long time. I've got a lot of experience in clinical education and then even in management. I was the director of a women and infant or women and children service line for 5 years before I became a nurse practitioner. I work in an urgent care setting. I see a huge population of pediatric patients. I do a zillion physicals every year for school and for sports. So I'm pretty well versed in this. And if there isn't something, if I can't answer a question for you, I'm certainly going to be able to find the answer for you, or at least direct you in the where you need to go to find that answer. So let's get going. Physical exam in infants and children. Here are our objectives and the goals and different approaches. Remember, when you're dealing with children, you may not use the same uh, methods that you would in an adult. Uh, like I have my order that I do things, right? With every patient, I do things the same way. I listen to lungs, I listen to heart, then I look in the ears and the throat and the nose. With a child, I might do things a little differently. We want to do the things that we need to know that are going to be the least disruptive. Children typically don't like to have their ears looked in or their throats looked in, so I'm typically going to do any of the least invasive examinations first. They typically don't mind me listening to their heart and lungs or looking at their tummy, feeling their tummy. So I'm going to do those things first. I also try to use some distractive techniques. I always have little toys that I have them look at. I attach things to my stethoscope or to my otoscope. I also have a special otoscope that I use for kids that isn't as invasive as the ones that are in clinic. So, most facilities don't have these things. I purchased these on my own. I certainly don't expect you to do that because you're not going into pediatric practice. I see a lot of adults too, but I probably would say it's equal, at least in urgent care. We have to see a lot of patients quickly in the setting that I work at. So I invested in these tools so that I can be more efficient and cause the least amount of stress on my pediatric patients as possible. All right, so I just talked about this, the least painful areas, you know, and their stranger anxiety. So I try to um, become friendly with them. I also often do the examinations with the parents holding the child. They can do it standing up and holding the child. I can see everything that I need to see. Or if I can't, I'll ask the parent to sit on the exam table while they're holding the child. If I'm doing an invasive exam and the child is, I don't like to use the term not cooperative because the child is scared. That's why they're behaving the way they are. I have to advise mom how to do things. Sometimes they need to sit on the bed with their arms wrapped around the baby's chest and their legs around their legs so that I can, if I really need to see something, or if I really need to do a strep test, or if I need to give an injection. Now, luckily, the area, I will say that luckily, the urgent care that I work at, we don't have a lot of can I say injections. So we don't do immunizations on infants and children where I work at. But we may have to test them for RSV. We may have to test them for strep or flu or COVID, and they don't like it. Adults don't like it. but at least most of the time they'll stay still, right? Most of the time. Or if they have something I need to suture, or they have something I need to staple, those are big deals. Because I will do that on kids. So, but we're going to talk about all of that stuff later. General approaches, head to toe, is what we do with adults, but with peds, we don't typically do that. Vital signs, I need to consider the differences in the ages. We're going to definitely do an apical until they are older, 3 years old, and count for a full minute because I'm looking for any arrhythmias that may be present. The blood pressure, we're going to do that last. And the blood pressure, as you're going to see in one of the videos that I posted, I went and put some new videos in this course. The blood pressure is not really important to me unless they have a cardiac issue. When babies are born, their first blood pressure is done typically at 12 to 24 hours of age. The policies have changed. They used to only do one blood pressure. Now many institutions will do two. But if they don't have any history of cardiac events, their heart rate is nice and regular. I'm not bothered by doing a blood pressure until they're 2. After birth, of course, the births are important. And then, rectal blood pressures are really the most reliable, but you're not going to see that done in practice very often at all anymore. Most facilities do axillary or tympanic temperatures. I personally prefer the tympanic over the axillary. I find it to be a little more accurate. I have had patients come in and I look at their temperature that the medical assistant did, because we have medical assistants that do this where I work, and it says 98 or something, or 96, and the kid is burning. So I will repeat it, tympanic. Again, I'm terrible. I am such a control person. I have my own tympanic thermometer that I'll use to recheck if I think that the one that the medical assistant did is inaccurate. Because for me, things like that are important, and oxygen saturation, those things are important. That's going to give me a baseline of where I'm at with this child. This is going to tell me if I can treat this child in my urgent care setting, or do I need to send them to the emergency department. So I, as a provider, want to ensure that it's accurate. And here are the different blood pressure placements that you're going to see. We use the brachial artery all the time in pediatric patients. Adult patients, sometimes you're going to use the radial artery if the patient is extremely morbidly obese and even our huge thigh cuffs don't fit. The blood pressure, this is going to show a little bit more. The size of the cuff also, I wanted to say, the size of the cuff, so important to use. Use the right size for the child's arm. Different temperature measurements are illustrated here. The American Academy of Pediatrics is the gold standard. So I would definitely follow whatever the American Academy of Pediatrics says to do. They're just the gold standard. If you're following those standards, and I always go back to the legalities of things. When I was a nursing director in Women and Children's Services, which is the second highest sued department in the hospital, neurology being the first, I was incredibly sensitive to doing things in a manner that would be considered reliable in a court of law. And if you follow the standards of your professional organization, like American Academy of Pediatrics, you're going to be good to go. So I would definitely follow that. Here are the standard vital signs for newborns all the way up to teens. I think that this is a good, I advise all students to have a toolkit, whether it be on a tablet or it be paper. I'm old school. I've been a nurse for a long time. I embrace technology, but I also like to have my paper records. So if you are a paper record person like me, I would get a notebook. I would copy, cut, and paste this into a notebook so that you know what the norms are. As a beginning nurse practitioner student, it is vital that you know normals. You're not going to recognize abnormal unless you have a good understanding of normal. And you're in this transition period. You're going from being a nurse where you took orders to a provider where you give orders. So it is a huge transition, um, going from the nurse to the provider. So you need to gain a good understanding and realize that you're in this new role and the transition of this new role. And here are some of the things we're looking at for physical assessment: the general appearance, the skin assessment, and here's some normal variants in newborns. You're going to see this often. So what's a normal variant mean? That means that you see these things, you're going to think, but it's normal. These are called Mongolian spots. I don't know if they're still called them, but normal. We see them a lot, especially in Asian neonates. And remember, Asians, that term Asian, I was surprised when I began working in women and infant services. Asians cover a huge area, in patients that are of Indian descent, Mediterranean descent. Those are all thrown into the Asian category. So 85 to 100% of Asian neonates have these Mongolian spots, typically in the lower back. 46 to 70 Hispanics, a few white neonates, but typically those are the ones that have darker skin. They'll often disappear by the first or second year of life, but not to be of a concern. They look like a bruise, honestly. Here's some normal variants: baby acne. Sometimes people freak out. The parents go crazy when the infants get these. It could be due to hormonal changes, but they'll go away on their own. It's not eczema, it's baby acne. Some more normal variants. Oh, I thought I fixed this slide. I guess I didn't. Milia, these little white spots typically on their cheeks, nose, also Epstein pearls in their mouth. It's on the palate of their mouth. All normal, and they'll go away on their own. They don't need any treatment. You'll see these, it looks like prickly heat. I've got to go back and fix these slides. I thought I fixed them. But it's newborn rash. Nothing to be concerned about. It happens in all babies. Another normal variant are these vascular lesions or mascular stains. We call them angel kisses or stork bites in the back of the neck, was what we used to call them, stork bites. And you can see them typically too on the forehead, eyelids, nose. They resolve by 18 months typically. Vascular tumors, these are infantile hemangiomas. It's the most common benign tumor in infancy. It's caused by the rapid proliferation of blood vessels in the first year of life. We see it more in women than in men, but my son had one of these on his lower or his upper abdomen, lower chest. It actually is just a little tiny, he's an adult now, he's 42 years old, little tiny thing. It got smaller as they grew. Here's some more examples. Freckling in the axillary and inguinal areas. We have port wine stain birthmarks. Some of them are faint as this, and some of them are striking, as you'll see in this child over here on this side. Difficult to treat these or get rid of these port wine stains. All right, here's something: a Sturge-Weber syndrome or a gene mutation, not inherited. It's a blood vessel abnormality, a dilatation of capillaries with abnormal formation. And three main features can vary in severity. Red pink birthmark, the port wine birthmark. Over time, it can darken and thicken. Sometimes there's a brain abnormality, a leptomeningeal angioma. and abnormal blood vessels over the brain. Spinal cord can impair blood flow to the brain and lead to atrophy, stroke, seizures, migraine, vision impairments, visual field problems, and cognitive impairments, and can increase blood pressure in the eye or glaucoma. So these things are rare, non-inherited gene mutation. But if you see these things, if the child has a red, pink birthmark or a port wine birthmark, these things need to be investigated further to ensure that it's not this Sturge-Weber syndrome, because if it is, there can be some abnormalities in the nervous system. Here's some more information about this, the Sturge-Weber syndrome. I'm not going to go over it much more because it's so rare. Here are some external lesions that may indicate some internal problems. This, it's not a really good picture, but they call it a fawn tail nevus. This can be indicative of spina bifida. This cafe au lait spots can be indicative of neurofibromatosis. So these little birthmarks that you see here are indicative of potential issues. You can see this baby over here is a sacral dimple. That needs to be looked at too. Sometimes these end up developing into oh my gosh, I can't think of the term of it. My grandson had it. But abscesses, and they need to be drained usually later in life. Let's talk about the head a little bit. In infants, you know that they have these sutures, so the brain or the skull is in several sections. And the reason that it's made that way is so that it can aid in the delivery process through the sacral bones or through the pelvis. If the skull wasn't able to mold into the pelvic area, it wouldn't be born. The baby wouldn't be born. So they also have these two, what we call soft spots, one in the front and one in the back. The one in the back closes pretty quickly. The one in the front can take up to 18 months to close completely. These sutures, these babies, also these bone pieces, these bone fragments, they will end up melding together. And also, in some rare cases, there are infants or fetuses where these bone fragments have already sealed, and that can pose a big problem. These babies need to be born by cesarean section, and they need to have pretty urgent cranial surgery to open up these sutures, because these sutures need to be malleable so that the brain can grow. If they aren't, then you're going to impede the growth of the brain, and there will be some long-term effects from this. So that can be a serious situation. When you're inspecting a newborn or a child, and I always do this with my adolescents as well, I feel the skull for shape and symmetry. I look at the face and the scalp. I look for hygiene. Do they have cradle cap, which is seborrhea dermatitis? And if it is, they need to wash the scalp more frequently. Assess for bald spots in children. This can be tinea, which is fungal in nature. They can also have hair loss. Can be what am I trying to say? Propecia. No. Yeah, that's what I'm trying to say. Palpate the skull for those fontanelles and any lymph nodes, and percuss the sinuses. Now, I get people who come in and they bring their kids in and they go, oh, I think they've got a sinus infection. Not very likely, because their sinuses don't develop completely until the age of 7. Now, can they get an infection? Yeah, sure. But the majority of these things are viral in nature and don't need treatment. I'm looking for other things, ear infections and strep throat. I'm not really looking for sinus infections in children under the age of 7. Here's a good illustration of the soft spots that you'll see, and also how the skull fragments are separated in those suture lines. Here's some examples of some head trauma. Caput is super common. That is caused by molding of the head in the birth canal, usually resolves in a couple of days. The cephalohematoma is a birth trauma, and this is a collection of blood bound by suture lines, and it becomes more fluctuant as it liquefies. My youngest daughter, she's now 32, she was born, she had a huge cephalohematoma. My girls, they were both face up when they were born, and she was born by a vacuum delivery. Almost ended up with a C-section with her because she not only was face up, but her head was twisted in there. So she was in a real odd position. And she had this huge cephalohematoma. It took months to go away. And they actually did an x-ray on her head just to make sure she didn't have a skull fracture. But it was really striking looking. And here's an example of how you can see these cephalahematomas and the different locations of where they can be. Here's another example of scalp edema, but this one is benign. It's just it's from coming through the birth canal. Here's another more striking one. And now let's look at this. If you have a child that has a rapidly increasing head circumference, or that's one of the reasons that we check head circumference on newborns, and we also check them. You'll see in your pediatric practice, the littles, we're going to check head circumference because there's a graph that you're going to see where it should be. Now, in some babies when they're born, I've only seen this once in my career where they had hydrocephalus, which is that bright light, and they shined a bright light through the baby's head. You could see it, and this baby had hydrocephalus. So it had a huge head and needed to have a shunt put in. But that baby also had I can't remember what it's called, but the baby had a small brain and ended up having to go to it went into a nursing home. There's a nursing home for newborns who aren't expected to live more than a year or so. It's called Angel something. And that baby went there and actually thrived. It was amazing. The parents just were not, I never say that when a patient makes a decision to put their child in a nursing home that they're a bad parent. No, they're not. They just have come to the realization that they don't have the capacity to give the baby what they need to have a successful outcome, I guess you could say. I'm trying to think of a way to say it that doesn't sound bad. But these parents, they went every day to the nursing home. But they had other kids at home, and they didn't think it would be fair to the kids that they had at home to bring the baby home because she would need so much care. And I don't know I don't know what the lifespan of this baby was, but I do know that she thrived in the facility that she was in. The parents and the siblings loved this baby and gave it all the attention that they possibly could, and they did the right thing for them. All right, now we're going to look at eyes. Eyes are super important in newborns and small children. So let's go into this field. So permanent eye color doesn't come in until 6 or 12 months. So the babies might be born and they all have dark eyes, and you're like, oh my gosh, where did this come from? Also, they're in the newborn, they don't have good control of their eyes, so they may roll all over the head. It doesn't mean there's anything wrong with them. That will get better. You do want to look for a red reflex in all newborns and infants to ensure that that reflex is there. Believe it or not, newborns can be born with retinoblastoma. So we need to check to make sure that that red reflex is intact. And we have some pictures coming up here. Look for nystagmus and I can never say this, ptosis, maybe the P is silent, I don't know. But look for any drainage in the eye. The sclera should be nice and white. Look for the neurologic assessment. Pupil should be equal round reactive to light. Look at their accommodation and use an ophthalmoscope to identify the optic disc, macula, arterioles, vein, fovea centralis, and red reflex. And this is a skill that you're going to, it's going to take a while to become comfortable with the skill of an ophthalmoscope. It is not an easy tool to use. So it's something that you want to consider or practice frequently. All right, I always do this with my kids when they're coming in for physicals, checking for the cardinal fields of gaze. Here is an explaining the extraocular muscles and how they enable them to move. We're checking for cranial nerves, and I tell when I'm doing my sports physical, I have a routine that I follow. I do it the same with every patient. Not only does it cover everything that needs to be covered in the sports physical, but then if anything were to happen and I were in a court of law, I can say with all confidence that I follow the same process and protocol for every single patient that I use or that I examine, and I am doing it to examine all of these cranial nerves. And here we go. Here's another illustration for you. Pupils that we're looking for to ensure that that perla is present. The consensual light reflex and how it this is an illustration that shows how the cranial nerves work. I tell my patients, I explain it to them like this. That I compare it, I use this comparison, that the brain is the powerhouse of the body. So imagine that it is like the electrical system in your house. You've got that box, right? It either has fuses or circuits in it. So the brain is the electrical box that you have in your house, and it's filled with nerves, and the nerves are those wires that go to all the outlets in your house. And in the body, the outlets are the muscles in your body, and it's the muscles in your arms and your forearm and in your fingers and in your chest and in your abdomen and legs and feet and toes. And if there's a problem with a circuit, you aren't going to be able to do what I want you to. Your reflexes won't work properly. You won't be able to make a fist or move a muscle. And so I have them do these things in order to ensure that the cranial nerves are intact. So that means that there aren't any interruptions in the circuits, right? So those nerves start in the brain and they go down the spinal cord, and then they exit the spinal cord in specific areas of the body. And they innervate to these specific muscles. And if there is an interruption, they aren't going to be able to do it. So if they can't do it, then we need to investigate further to find out why. And the parents really like that analogy. I try to take complex medical terminology and function and make it into a manner in which the patient can understand. And they seem to understand that one. So we're testing for corneal reflex. This is always fun. I don't routinely do this one on patients where you take like a cotton swab and you touch the eyeball with it. Cranial nerve 2, we're looking for near and far and peripheral vision. We're going to use an eye chart for this. Accommodation. I do this too. I do it in a manner. First, I'm checking for the 8 cardinals and lines of sight, and then I do accommodation. The eye examination, our medical assistants will have them do an eye exam using a Snellen chart. And I am looking at when I look at their eye, my inspection of their patient begins the minute I lay eyes on them. So you're going to look at their upper eyelid, their lids, their sclera, make sure everything is what we consider normal. Epicanthal folds. And we're going to look at the alignment and slant of the eyes. Children who have Down syndrome, their lower lobe typically will meet their eye, it's higher than it should be. And here are some examples of palpebral slants. Now these can be normal with Asian ethnicity, but it can also be indicative of Down syndrome. And we're going to inspect the lacrimal duct or the tear duct. And it's funny because tears are produced up here. Most people think they come from down here, but they don't really. They come from up here. And then they go in the eye and they go down this duct here and then into the sinuses. That's why your nose runs when you cry, because the tears are actually produced up here in the eyebrow. They go over your eye and it lubricates the eye, right? And then it goes into this duct here, the lacrimal duct, and down into your nose. So that's why your nose runs when you cry. The red light reflex. So we're going to show you some pictures of this one coming up. And here is the refraction test, and this is abnormal. Okay, we want them to be the same. This one here is an example of retinoblastoma. Here is an example of the Bruckner test. You can see these don't match. They should be the same, right? But these are different. It's an example of myopia. Here's some more examples. This one is normal. They're both the same, symmetrical. This one is unequal refraction. And this is the red reflex is absent. So this can be indicative of a cataract. And yes, babies can be born with cataracts. How interesting is that? All right, conducting screening tests. These are things that we're going to look like when we're doing our screening tests. We want to ensure, if to get a good test, the child shouldn't be hungry, they shouldn't be tired, there shouldn't be distractions or anxiety. We want to do our test prior to any procedures. So if they need shots, we're doing the examination first, because after they get their immunizations, they're going to hate us. Observe for any straining, squinting, blinking, head tilt, shaking. Don't correct or give clues, and test for the red reflex, corneal light reflex, cover, uncover. You can't do some of these with babies. Here's something that you're going to do to test for strabismus. So this child's got an eye that goes in. Ocular mobility and alignment tests, hypertropia and hypotropia. So the eyeball goes up, the eyeball goes down. Ocular mobility and alignment. Again, we're not going to do this for infants. I would definitely tag the American Academy of Family Practice site. So they've got some great stuff on there. Example of the cover uncover test. Pseudostrabismus. This happens often when kids are little. Or the sclera between the cornea and the inner canthus is obscured by closely placing eye in a flat nasal bridge. So if a child has prominent epicanthal folds, it can look like their eye is going in. And so that's pseudostrabismus. It's a normal variant. And here's an example of checking the peripheral fields, visual acuity, the Snellen chart. And I thought this was interesting. Now, if I'm doing a sports physical on a child, they have to they have to be better than 20/40. That is the guideline of the American Academy of Pediatrics. If their vision is 20/40, they don't pass. They have to get their glasses. And if they can't pass it with their glasses, they don't pass. So the Snellen eye chart is best done with your glasses or contacts in, and it's done at 20 feet away. That's why we get that 20. We want to see what line they can read at 20 feet. So if a person without refractive error can read at 20 feet, a person with refractive error can only read at 20 feet. That would be considered 20/30. And if they miss 2 on that line, it's called 20/30 and then 2, and 20/30 and then 1. If they miss more than 2, then I'm going up. I don't think that I don't think they're 20/30. I think they're 20/40 then. All right, let's look at this one. Visual acuity test. There's all different kinds of tests. For kids that can't read, there are ones that have pictures on them. There's also a tumbling E. That's the one you use when you get your driver's test. And let's see what that one looks like. Here, there's an example of the Snellen. I'm sure you're familiar with that one. And then the tumbling E. It's asking, you ask, is this left, right, up, down? That's the one I do when I get my driver's test done. And here's some examples of those ones with the pictures on them. Test central, visual acuity and close proximity. We also test for, in our clinic, we test for color blindness too. And here is an example of the visual acuity norms. This would probably be a good thing to keep in your toolkit so that you know. And recommended ages for pediatric eye evaluation. You can see you're doing the red reflex all the way up, right? We've got 3, 4, 5 years we're doing the red reflex. And when to refer, this is another one that I would put in my toolkit too. Peripheral vision and what it's looking for. Confrontation test. This is checking for peripheral vision. And see how she switches hands? And this was actually, there was an illustration of this earlier on in the presentation. And here's our references. So I hope that this helped. And definitely do consider that toolkit. I found it incredibly helpful when I first became a nurse practitioner. I think that, I mean, when I became a nurse practitioner, I was petrified because I'd been a nurse for 18 years before I started practicing, or almost, because I had gotten my certification while I was a nursing director, and I kept working as a nursing director because I had some projects that I was working on that I wanted to complete. But I was terrified because now I was an expert nurse, but I was a novice nurse practitioner. So it was like starting all over again. And I wanted to make sure that I was competent in what I was doing because the expectations are different. When I was a nursing student and then became a nurse, I had extended orientation. I think I had a 6-week orientation. Now, nursing new grads get like 6-month orientation. But back then it was about 6 weeks. But still, that was a good long time. As a nurse practitioner, the expectations are going to be different. They expect that you're coming in with a working knowledge. Okay, so the expectations are going to be different. You need to be able to practice competently. You're still going to be a novice, but you need to be able to practice competently once you graduate. And so I want to ensure that you have the tools that you need to be successful. So that's my goal. So I hope that this was helpful to you. And I know that it was long. It was like 40 minutes, but I think that it's worth it.